Hello, my name is Tom Stinchcombe. I work at Duke Cancer Institute in Durham, North Carolina. I'm a thoracic oncologist who specializes in clinical care as well as clinical trials for patients with thoracic malignancies. Brain metastasis is a complication of lung cancer that's evolved tremendously over the last 10 or 15 years. I think historically, the presence of a brain metastasis was thought to be a very ominous sign, and the patient had a poor prognosis. But as our management of brain metastasis has improved, I think the prognosis is improved as well. And importantly, the patients are living not only longer, but with a better quality of life. When I see a patient with a brain metastasis, there are a number of factors that sort of go into the treatment decision. When I look at the brain metastasis, you sort of look at the simple, is it symptomatic or is it asymptomatic? How many of them are they near a critical structure? Is it a solitary lesion that's amenable to a neurosurgical resection? And so I think that, that's the other problem we face with brain metastasis, is that they're all sort of lumped together when really there's a huge spectrum of severity and disease in this situation. For patients with a known oncogenic driver mutation, such as ALK or EGFR, I have generally started with a tyrosine kinase inhibitor. These next generation agents have good CNS penetration, and many times patients can experience a response to these therapies. I continue to do surveillance on those patients with MRIs every 3 months to make sure that the brain metastases are responding. And I think over the last couple of years, we've gotten more comfortable, even in patients without an oncogenic driver, doing immunotherapy or chemoimmunotherapy and really following those patients with brain metastasis to see if the immunotherapy can control the cancer or potentially shrink the cancer. And so I think that this is a novel approach where we've sort of followed these patients. And then I think if there's disease in the brain that's not controlled, we really look to use stereotactic radiosurgery. Some centers use gamma knife to really control the 1 or 2 spots that maybe are not responding to therapy at a later point. We've generally avoided whole brain radiation therapy because we've become more aware of the long-term neurocognitive effects of whole brain radiation therapy. So I rarely use that now, and we try and avoid it if at all possible. I think for the patients that have one brain metastasis that's amenable to surgical resection, we do consult our neurosurgery colleagues and to see if the resection would be the best way to get local control. Because I think many times as we have more options, it's become a little bit more complicated because we have to have the conversation with the radiation oncologist, neurosurgeon, and the medical oncologist. And so I think that there's a lot more options. And patients are really living longer, which makes us think a little bit harder about what are the consequences of our decisions and how to leave as many options open as possible.